Thank you, Chandrasekar, for the invitation.
Thank you. Louis, I'm in Detroit. Which city are you in?
Currently, I'm in Chicago, but I'm centered in Pennsylvania most of the time. But I live in Chicago. I live both in Chicago and Pennsylvania, so I'm not far from you right now.
That's right. You're not very far from me. So, Dr. Kulkarni, what does COVID duty mean?
Well, it will be for a week, whereby some number of patients, typically about 30 to 40 patients, would be managed by me for a week. They'll be admitted under my care, so I decide the care. And that's it. The hospital cares around 400 to 500 patients every day in hospital.
So you will be their primary care physician both in the ICU and outside the ICU?
Yep, not in ICU, outside the ICU.
And do you have help in terms of house staff?
Yep, we have house staff, which is there round the clock. Then, of course, if needed, we have cross services, the nephrologist, the infectious disease specialist, cardiologist, intensivist, so diabetologist. So whosoever is there, we can always involve them in the care.
I see. Who is the infectious disease specialist? I know most of them there.
We have Dr. Bharat Purandare and Parikshit Prayag. These are two guys.
I see. I see.
Can we take it 6:30 is there and there are more than 132 people,
we'll
so
start.
I think you start.
We'll start.
I think we need to start.
Dear friends, good evening. On behalf of Tropical Neurology subsection of Indian Academy of Neurology, I welcome you all for this important session, Fungal Epidemic in COVID Pandemic, with emphasis on mucormycosis. COVID has taken the world by storm and we are caught on a wrong foot. We are losing near and dear ones and important people due to COVID. Mucor is now the major health problem during and after COVID with high morbidity and mortality. We are on COVID fire and Mucor is adding oil to it. So today's session has a great importance. To inaugurate today's session, we have President of Tropical Neurology subsection of Indian Academy of Neurology, Dr. Nirmal Surya, who is a consultant neurologist at Bombay Hospital and Saifi Hospital, is the President-elect of Indian Academy of Neurology and past treasurer of IAN. He organized World Congress of Neuro Rehabilitation, and he's the regional vice president of World Federation of Neuro Rehabilitation. He is chair of and the founding trustee of Epilepsy Foundation, and he organizes the epilepsy camps regularly. And the title of today's session was his suggestion. Warm welcome to you, Dr. Nirmal Surya. To chair the session, we have Dr. Prananarthi H. Chandrasekar, who serves as a professor of medicine and chief of infectious diseases at Wayne State University, Detroit, Michigan. Dr. Chandrasekar serves as the section chief of infectious diseases at the Cormonas Cancer Center, Michigan. His major interests are management of infection, including fungal infections in compromised host, particularly cancer patients and transplant recipients. He graduated from CMC Vellore in 1974, and therefore he has a deep interest in the field of infectious diseases in India, and in particular the education and clinical training of infectious diseases subspecialties in India. Welcome, Professor Chandrasekar.
Thank you.
We have a faculty, very interesting faculty and knowledgeable faculty. And we have Dr. Rahul Kulkarni, who is secretary and convener of Tropical Neurology subsection of Indian Academy of Neurology. He is head of Department of Neurology at Dinanath Mangeshkar Hospital, Pune. He is member of many international and national neurological organizations. He is actively involved in training of practitioners and students and he has a special interest in CNS infection, neuroimmunology, and neurology education. Welcome, Dr. Rahul. We also have Dr. Sanjay Vaid, who is Chief of Head and Neck Imaging Division and Director Academics of Star Imaging and Research Center, Pune, Chief Radiologist and founder of Turtleneck Imaging. He has academic experience of 31 years and clinical experience of academic experience of 17 years and clinical experience of 31 years. And he delivered more than 400 lectures. And his area of interest is head and neck oncology imaging and temporal bone imaging, paranasal sinus imaging. Welcome, Dr. Sanjay. We have another Sanjay, Dr. Sanjay Pujari, who is Director and Chief Consultant, Institute of Infectious Diseases, Pune. He's consultant in infectious disease and HIV medicine, Pune Hospital, Pune. He did fellowship of the Infectious Diseases Society of America. He's a principal investigator in the Treat Asia group. He's a member of ICMR National Task Force for the COVID-19 and member of the clinical research group constituted under this task force. He has a lot of publications and is faculty in many symposia, and already we had few talks by Dr. Sanjay Pujari in our group. Welcome, Dr. Sanjay. We also have Dr. Pushkar Kiran Gadre, who did MDS in oral and maxillofacial surgery from Sharad Pawar Dental College of Sound at Saungi Mege, Wardha, and he's presently consultant oral and maxillofacial surgeon at Pune Hospital and Research Center, Pune, and also at Ruby Hall Clinic, MUM Hospital, and various other hospitals in Pune. Welcome, Dr. Pushkar Oak. And we also have Dr. Vikram Oak, who is a consultant ENT surgeon, Dinanath Mangeshkar Hospital, Pune. He's honorary ENT consultant as Ram Nivas Ruiya Deaf and Mute School, and former associate professor, Bharati Vidyapit, Deemed University Medical College. Welcome, Dr. Vikram Oak. I also would like to welcome eminent persons who joined these sessions, WFN trustee and editor-in-chief of Continuum, Professor Steve Lewis, and I hope Dr. Kumar Rajamani, who is at Professor of Neurology at Wayne University, Michigan, he will join soon, and Professor William Wolfgang Griswold, Secretary of World Federation of Neurology. I also welcome him. I am sure this session will enlighten you, and now I request Dr. Nirmal Surya to inaugurate this session. Dr. Nirmal Surya.
Thank you, Dr. Mishram, and I want to welcome all the faculty and President Dr. J.M.K. Murthy and Secretary Dr. Meenakshi Sundaram. It has been only last 5-7 days that we started wondering that since COVID has been come and the second wave has shaken the India, we are seeing quite a few cases of mucormycosis, and last 15 days we have been seeing as if they are coming into the groups. People are saying 20 cases, 10 cases, and I felt that it is very, very important that tropical neurology subsection takes initiation to let people pick up, diagnose, and know about the fungal infection, which is really, really causing a very high significant mortality. In fact, once we started knowing it, I've also seen nearly 5 patients in last 3 days, and we could really diagnose the moment patients say that I've got numbness and little eye problem. So with that, I thought that this fungal epidemic in this pandemic, which is with a high mortality, probably related to various immunological system, maybe because of COVID itself, or because of the diabetes, or because of the steroid. Whichever is the cause, we don't know. We really need to work on it. And I requested of my secretary and convener, Dr. Rahul Kulkarni, to plan it out, and along with Chandrasekar make some here we are. It is probably the shortest duration webinar planned, and we already had 300 plus people in the webinar. So I'm not going to take a lot of time, but what I'm trying to tell you is that tropical neurology subsection has planned to write down the guidelines, plan to write down the position statement in next couple of days, and would be opening a registry for fungal infection of the brain following COVID, and also would be putting up a multicentric study across the country. So all those people who are here and they are interested, they should connect with Dr. Rahul Kulkarni and start registering the cases. With that all, I don't want to take much time, and I want to thank everybody. And we really need to take it seriously, because it is very difficult to get antifungal medicine at smaller places. And we really need to put pressure on the government to please give proper guidelines as well as arrangement of antifungal drug. Thank you, Dr. Mesham, and I thank Professor Lewis as well as Wolfgang to be here in this important seminar. And I also want to thank Dr. Chandrasekar, who's also been here. Thank you very much.
Thank you, Dr. Nirmal Surya. I would also like to welcome IN President, Dr. J.M.K. Murthy, Secretary of Indian Academy of Neurology, Dr. Yumin Ashisundaram, and past President of Indian Academy of Neurology, Professor Saroj Katrak. And I once again welcome you all, and I now hand over to Professor Chandrasekar to carry out the further proceedings. Professor Chandrasekar.
Thank you. Thank you very much for having me at this meeting. Let's put together such rapid time. That's wonderful. Congratulations. And it's a timely one. So let's not waste time. Let's go on with the presentations. There are 4 presentations scheduled with this mucormycosis entity and fungal infections in general. So the first speaker will talk about the clinical aspects of it, and the second person will talk about the radiological aspects, and the third and fourth primarily will concentrate on the management, both medical as well as surgical. So that is the plan, and then if there is time, I would make some comments, and then we will open it up for discussions, which I think would be the most important part of the session. So please keep your presentations on time, so we will have plenty of time for discussion. Invite the audience also to participate in this session. So the first presenter is going to be Dr. Rahul Kulkarni. He's the head of the Department of Neurology in Pune at the Dinanath Mangeshkar Hospital. And he's going to be telling us about mucormycosis and clinical infections in the context of COVID. Dr. Kulkarni?
Thank you. Thank you, Ayan, for having me. I remember when the COVID started, we had the first webinar on COVID where I was a speaker talking about the neurology of COVID. And again, I'm here to talk about the fungal infections in COVID. We know that we have moved on in the COVID. The learning curve had changed over the time. Initially, it was thought to be predominantly a pulmonary infection. Later, of course, we know that there were a lot of prothrombotic disorders which were described. Then, of course, we knew that there is extrapulmonary involvement. And then there were post-COVID manifestations, including thrombosis, as well as a large number of neuropsychiatric manifestations were described. Lately, secondary infections, including bacterial and fungal infections, have been described in the post-COVID as well as during the COVID scenario. Talking about the fungal infections in COVID, they can occur with COVID or they can occur after COVID, in the post-COVID scenario. The commonest 2 sites which have been described are pulmonary, and the second one is Retro-orbital cerebral syndrome, where there is involvement of nose, eye, as well as the paranasal sinuses and the brain tissue. The fungi which typically cause these 2 infections are Mucormycosis and aspergillosis. The commonly seen fungi by the neurologist, the Cryptococci, is not a part of this disorder. Neither the Candida, which is again a common fungal infection seen by intensivists as well as by physicians. So the common infections are caused because of these 2 fungi, the Mucormycosis and aspergillosis. I'll just talk about a couple of slides about fungi in general for the neurologist. Fungi can be divided into 3 types. Fungi can be a very small fungi which are called as yeast, which typically cause meningoencephalitis. The smaller is the fungus, the more diffuse is the disease. Yeast is the most smallest fungus, so it causes a diffuse disorder, meningoencephalitis. The typical example is Cryptococcus and histoplasma. Little bigger fungus in the size is the one which has got the pseudomycetes, and the typical example is Candida. It causes microabscesses and granulomas, while the larger fungi are called as molds. They can be septate or non-septate, and they would cause this Sino-orbital cerebral syndrome, and they would also cause strokes as well as abscesses. The common fungi here are Aspergillus and Mucormycosis, or what is called as zygomycosis. The term is used interchangeably. I would be using the term mucor henceforth in my lecture. Now, why this topic? It is important to know that the country is put on high alert because of this infection for 3 reasons. Number one, COVID numbers are very high in India. It is the second most affected country after USA. The diabetes, which is well-known risk factor for this kind of infection, is a very common disease in India. Again, India is the second most affected country because of diabetes after China. And if you talk about mucor, India has the highest burden of the disease in the world, roughly about 140 cases per million population. So because of these 3 reasons, India has the highest chances of getting these kind of infections. And in fact, we are expected to see a large number of such cases. Already there are multiple case reports as well as smaller studies which have been published. And I know that large number of people are going to write on this disorder. This is the largest study on mucormycosis. It is not in COVID, it is in general per se, but this is the largest study of mucormycosis comes from India, which is more than 450 patients published 1 year back. And then, of course, the study, there's a meta-analysis which has been recently published on the COVID-related invasive fungal infection. And you can see that a majority of the cases in this study were reported from India. This paper had 41 cases in total. So there is, until this paper, there were 41 reported cases of this infection in the world literature. Now, talking about this disease, why neurologists should be part of this kind of symposium, or why neurologists should know about this disease? Number one, the presenting features are often neurological. You have headache, you have facial pain, you have vision loss, you have double vision. So all these features are neurological features. Second, neurologists have been managing mucor for decades. I remember managing mucor right from my college days. So does everyone must have managed mucor for 10 years, 20 years, 30 years, 40 years. And ENT and ophthalmologists who are doing these kind of surgeries were asked by the treating neurologist to do these kind of surgeries, calling them at night, calling them in early hours, asking them to do this surgery, probably sometimes fighting with them to do these kind of surgeries, because we know that these surgeries are life-saving in some of these patients. The commonly used drug in the treatment of mucormycosis is amphotericin, which has been used by neurologists for the treatment of cryptococci for many years. So neurologists know how to use this drug, including its side effects and how to manage these. And we know that this disorder leads to CNS invasion, which causes increase in the mortality, which a neurologist can diagnose early. That is why neurologists should be aware of this disease and should be part of a team which manages this kind of disorder. So we did our study. We did a study recently, which is in a manuscript has been under preparation. We did a study from Maharashtra, which is a western state in India, where we have 121 patients in this study. And I'm going to present some of the data as a clinical features in this next 5 to 10 minutes. We had 121 patients all across the state of Maharashtra. This study was ethically approved by the ethics committee. The commonest age group was between 50 to 70 in our study. The youngest patient was 19 years, while the oldest patient was 85-year-old. The mean age of presentation was 52.2. More than 3/4 patients were male patients, has always been reported as far as fungal infections are concerned. The problem in our study was patients were managed for COVID at some other center, and then the invasive fungal management was done by the neurologist or the treating counterpart at some other center. So the data related issue was there because COVID management done at some center where we had hardly any data available in some of the patients. So there was an issue about data which we are trying to trying to get some more data in these patients. But if you see, about 55% patient had increased D-dimer when they had COVID. High CRP was seen in about 80% patients. Ferritin was high in about 12 to 15% of the patient. Again, we are trying to get more and more data. Data is not available in majority of our studies, patients. And interleukin 6 was high in about 1/5 of our patients in our study. Those patients who had COVID were treated with various drugs, and steroid was used in more than 90% of our patients. 92.5% patients were given steroids. Various steroids in various regimes were used. Again, we do not have exact figures because the discharge summaries which have been provided are not adequate enough to give this information all the patients. Remdesivir was used in about more than 80% of the patients, which was surprising, which is a very high number in which remdesivir was used in our study, and we don't know whether remdesivir really contributed to this kind of infection. Tocilizumab was used in about 13% of the patient. About more than 10 to 15% patients were treated by non-invasive ventilation, and about 5% patients were put on invasive ventilator. So COVID severity was moderate in majority of the patient. It was severe in few of the patients. The comorbidities in our series was diabetes was there in about 80% of the patient. About 15% patient developed diabetes after COVID. So they were euglycemic before, and then it was found that they had diabetes, which is a well-known phenomenon in COVID. So about 90 to 93% of our patients were diabetic. 6.6% patients were non-diabetic. Hypertension was there in 40%. CKD was there in about, chronic kidney disease was there in about 10%. None of our patients had malignancies or immunosuppression on immunosuppressant drugs. The fungal symptoms started during COVID disorder in about 38% of the patient, and it started after COVID in about 62%. So 40 to 60%. In about 60%, it was a post-COVID phenomenon, while in 40%, it was during the COVID phenomenon. In the mean days after the COVID, when the disease started, was about 15 days. Maximum duration in one patient was 2 months. After 2 months, he developed fungal infection after the COVID, but usually it was 15 days. And the commonest clinical features were headache, facial pain, diplopia, vision loss, focal neurological deficits, including strokes. Facial palsy was seen in about 8% of our 8 patients, and 1 patient had seizures. So these were the common presentations seen in our series. The commonest presentation was headache and facial pain, followed by diplopia and vision loss. Other features which were seen were facial numbness, nasal discharge, epistaxis, skin and palatal necrosis, proptosis, unilateral, dental loosening, and altered sensorium in some of the patients when they present at late stage. Diabetic ketoacidosis on presentation was seen in about 16 to 17% of our patients. Radiologically, we had, of course, the data was collected from neurologists. So there is some inherent bias towards increased neurological involvement in our series. But the commonest sites which were involved was nose, paranasal sinuses. Orbit involvement was seen in about 70% patients. Cavernous sinus involvement was seen in 43% of the patient, and brain was involved in about 30% of the patients. In the brain, the commonest presentation was stroke. There were some patients who had meningitis. There was some focal inflammatory disorder near the cavernous sinus or in the temporal lobe or surrounding area in some of the patients. So this study has inherent bias towards neurological patients. So neurological involvement is more often in this paper that we are going to show. And the diagnosis was done by doing nasal scraping in most of the patient. But remember that about 8% patient, the nasal scraping was negative for fungus, and we had to get the sample either by after the surgery by the ENT surgeon or ophthalmic surgeon, and then histopathologically the fungus was proven. The stains which were used when we did nasal scraping was KOH, but the new stain, which is calcofluor stain, which is used with fluorescent, is a newer technique which has been used recently, which can diagnose the disease very rapidly, and you can see how the fungus looks in the calcofluor stains. Histopathologically, diagnosis was offered in about 82% of our patient. So histopathological proof was more than the nasal scraping or the stains in our study. And as far as fungi were concerned, 87% patient had mucormycosis, 4% patient had aspergillosis, 7% patient had both combination of mucor as well as aspergillosis, and in 2% we were not able to classify the fungus exactly. So commonest fungus was mucormycosis, but remember that around 10% patient also had aspergillus, and the common infection, the co-infection was a phenomenon which was seen in about 7% of our study. All the patients were treated with amphotericin. About 31 patients were treated with posaconazole. 2 patients who did not have central nervous system exam involvement were treated with caspofungin. ENT surgeries in the form of endoscopic sinus surgery was done in more than 95% of the patient. Ophthalmic surgeries were done in only 20% of our patients, but again, there is a bias in this study. Neurosurgery was required in some of the patients, and hyperbaric oxygen was used in 1 patient in our study. So this was the treatment which was offered in our study. Of course, there's a bias towards neurological involvement in this study. And as far as outcome is concerned, improvement was seen in 40% of the patient. Death was there in 20% of the patient. About 6.5% patients were lost to follow-up, but this study is ongoing. So about 1/3 of the patients are still having ongoing treatment. So because the study is still ongoing, we do not know what is exactly the mortality. Of the 82% who had completed treatment, about 60% patient had improved, and the mortality was 32%. 10% patient were lost to follow-up. They left the treatment in between and left the hospital, predominantly for the reason because the patient was worsening or there was a financial issue. So most of the patients who had left the hospital had died. So mortality in our series is about 42%, and 60% patient had improved. Of course, we are waiting for the data of this 30% of the patient as far as the treatment is concerned. And if we compare this study with the other studies which have been published, the meta-analysis that I showed you, which was by John et al., which was published recently at 41 patients, compared to their study, the age, the sex matches. In our study, the percentage of patients who had kidney disease was less compared to what was there in the meta-analysis. Steroid use was same in both the groups. Mucor typically started with COVID in about 40% patient. It started after COVID in about 60% of the patient. In our study, the diagnosis was achieved by staining as well as by histopathology. Histopath was more than the staining. And mortality in our series about 40%. Of course, this is still 2/3 of the patient. We don't know the data in 1/3 of the patient, which probably we'll know after some time. And if we compare this study with the other study about the mucor, which has been published worldwide, which is of course in non-COVID patient. This is again a study from India, which has 465 patients. Compared to that series, the study which is published by Patel et al. Had all kinds of mucor. They did not have only patient who had rhino-orbitocerebral patients. There were only 2/3 patients who were rhino-orbitocerebral. So they had cutaneous, they had pulmonary, they had GI involvement, all kind of mucus. In our series, of course, because this was done by neurologists, most of the patients had rhino-orbitocerebral syndromes in our study. In their study, diabetes was seen in about 73% of the patients. In our series, it was 100%. Surgery, of course, was done in majority of patients in our series compared to some where there was a cutaneous involvement where you do not do surgery. And otherwise, the study matches with whatever has been published till date. So what is new with this COVID-related invasive fungus? The available data suggests that probably the disease is more aggressive. It requires prolonged treatment and probably co-infections with Mucormycosis and Aspergillus. 10%, 7% in our study may be high in some of the studies, depending on the kind of staining that you use. The newer technique, the calcofluor staining has helped for faster diagnosis in the present era. And as far as treatment is concerned, we are using amphotericin. We are also using liposomal form of amphotericin. But the newer drugs, the triazoles, the posaconazole and isavuconazole can be used in the treatment of mucormycosis. I'm sure Dr. Pujar is going to talk about this. Caspofungin is a drug which does not cross blood-brain barrier well. So echinocandins are not a drugs for neurological conditions, but it can be used for other conditions. And as far as surgical techniques are concerned, we are going away from the open surgeries towards endoscopic surgeries. As far as this orbital surgery is concerned, surgeons are trying to probably conserve some of the parts, so limited debulking has been tried. And we have also tried newer novel things like giving a retroorbital amphotericin injection as well as irrigation of the sinuses with the help of amphotericin to see that whether this kind of surgeries, this kind of procedures help to reduce mortality of the patients. As far as pathophysiology of COVID-related fungus is concerned, where there are a large number of hypotheses which are there, immune dysregulation which occurs after COVID predisposes for the secondary infection, which is a well-known phenomenon. COVID leads to hyperglycemic stage because in COVID, there is damage to the pancreatic cells that leads to acute diabetes. It is believed that pancreatic cells have high expression of ACE2 receptors. That is why the novel coronavirus attacks this pancreatic islets that leads to acute diabetes. So in our series, there were 10% of patients who developed diabetes after COVID, which has been reported everywhere. The drugs used in treatment of COVID, like steroids, which can lead to hyperglycemia, and immunosuppression, which can further reduce the immune regulation, leading to increased chances of getting fungal infection are there. COVID itself leads to altered iron metabolism. In COVID, we know that there is increased ferritin in many patients. The high ferritin level leads to increased excess of intracellular iron that leads to generation of free radical species in the intracellular space, leading to tissue damage that leads to release of free iron in the circulation. So this excess of free iron in the circulation with the acidic phenomenon, which occurs in diabetes or diabetic ketoacidosis, is a unique risk factor for mucor. So the combination of free iron plus acidosis leads to increased chance of mucor in many patients. And the endothelial damage, which is seen in COVID, is known to be, again, a risk factor for fungal infection because endothelial adhesion as well as penetration are critical for early steps of fungal infection. And because there is already endothelial damage, the fungus can easily enter from the circulation in the surrounding tissues. It is believed that in hospital there are high amounts of fungal spores. Again, there is no data on this. So that can be one of the risk factor in some of these patients where there are crowded hospitals with large number of patients with COVID. And there are, of course, unknown pathophysiological factors. We do not know all the risk factors till date in this disease. Again, it's a challenging disease to manage. There are a large number of challenges for treatment of this or diagnosing of this disease. We know that a patient who is in the COVID area, which is a demarcated area where he or she is in quarantine, access to the imaging modalities like CT scan or MRI may not be possible for all the centers. All the CT scan or MRI may not take COVID-related patients. Experts going in this COVID area, all the experts operating in the COVID, again, is a challenge. You have to take a proper precaution, especially if you're doing certain surgeries for the ENT, ophthalmology, as well as dental surgeon. Again, in India, availability of the experts who are ready to operate on these kind of patients doing the destructive surgery is again a challenge. Diagnostic facilities may not be available everywhere, including the stains, the histopath, the good microbiology lab or the pathology lab. And we now know that amphotericin availability again has been an issue in India. So it's again a challenge to get amphotericin nowadays, like remdesivir in India. It of course has caused a financial burden on the patient as well as the healthcare system, because the patient has to stay in the hospital for 4 to 6 weeks. He has to undergo surgery. He will occupy a bed. He has to pay a large amount. So there is a financial burden because of this disease, as well as there is a burden on the healthcare system, because hospital which discharges a COVID patient has to keep the COVID patient for this disease. And I'm sure many hospitals are filled because of these kind of patients. So there is a burden on the healthcare system, which is already been under severe stress because of COVID itself. Surgeon has to do mutilating surgery. So it's a challenge to do these kind of surgeries in people who have this kind of disease. And ultimately it comes down to the cost. The cost of this disease is very high. Patient has to pay this cost. So we have lost 10% of the patients because of cost issue itself. Last couple of slides. So there are a large number of unanswered questions. What are the risk factors of this COVID-related fungal infection? Is the dose steroid matter? Or does the dose of steroid matter? Any specific steroid has higher chances? Whether remdesivir or tocilizumab are the risk factors? Whether the severity of the COVID or the hospital stay matters? There are issues about the tubings used for oxygenation, the ventilation, etc. Whether they are also risk factor. Whether this this fungal infection is same as our routine mucor or it's different. Whether treatment is similar or different. Whether what are the poor prognostic indicators in this disease, we want to know that. And of course, the most important question is, can we prevent this kind of infection? So the ways to forward is, of course, one has to have better awareness about this disease amongst the people who are treating COVID. I remember seeing a patient who was discharged from a COVID hospital who had ophthalmoplegia, saying that he was told that his ophthalmoplegia was because of COVID and it will go within 3 days. And the patient came after 7 days and she died within 48 hours. So there has to be awareness amongst the treating physician. We need more data and registries. And of course, Indian Academy would come up with some studies. We need case control studies to know the risk factors. We need basic scientific research to know what are the risk factors and how we are going to deal with them. We need guidelines for each specialties. We need more experts who would deal with this kind of patients, the ENT specialists, the ophthalmologists, the infectious disease specialists. And of course, we need better availability of the drug. So these are the way in which one has to look forward. Of course, it's a local disease of India and we have to deal with it ourselves. We must know how to deal with this disease. And finally, the take-home messages. Rhino-orbital cerebral fungal infection has become a common phenomenon in the post-COVID scenario. Everyone, those who are not treated COVID should also know about this, because you are going to land up and seeing some patients who are having this disease. Early diagnosis, early surgery, and early fungal treatment is a key for success. Trying to operate these patients within 24 hours. Start the drug as early as possible. Do not neglect headaches, facial pain, numbness, diminished vision. Anyone who presents with this phenomenon during COVID or after COVID, do not neglect this. Try to evaluate these patients. We need more studies to answer this unanswered question. And neurologists are integral part and at times captain when you're managing this kind of disease. Indeed, the disease has formed a new epidemic in the pandemic. There is an ongoing pandemic, and on top of that, we are hit with this epidemic. So there's a new epidemic which is occurring in pandemic, and probably this is going to be a unique disease of India, and we should know how to deal with this disease. So I must thank all our collaborators who are worked with us. This is a team of people who had sent us cases. These two people in yellow who had sent us large number of cases, but these are cases which are come from all over Maharashtra, as well as our hospital people who helped us, all the collaborators, to do this study. And you'll read this study in the journal in recent few days. Thank you very much. And I would stop here. Thank you.
Okay. Thank you, Dr. Kulkarni. That was incredible that you were able to put together 120 cases just from one state of India in such a short period of time. and described the clinical features in these cases and the unfortunate outcomes in many of these patients. For want of time, let's move on. Please note in the chat box, there are several questions, question and answer. We will try to have some time. Please keep your lecture to 15 minutes or less, so there will be more time in the question and answer time. The next speaker is Dr. Sanjay Vaid. He's the Chief Head, Neck and ENT, Imaging Division, Academic Director, Star Imaging and Research Center in Pune. Imaging, as you have heard from Dr. Kulkarni, is a vital part of the management of this disease. So let's go to Dr. Vaid.
Thank you very much, sir. I hope I'm audible and my screen is seen by everybody.
Yes.
Thank you very much to the Indian Academy of Neurology and to Dr. Rahul Kulkarni for asking me to come on this panel and my thoughts on imaging in mucormycosis. So in the next about 12 to 15 minutes, this is what I plan to cover. The main idea of this talk is to look for the early pointers and those imaging findings that are going to help us in triaging these patients. We'll look at whether we can, what kind of modality are we going to choose initially, whether it's going to be CT or MR. I am going to be restricting my talk to ROCM. I'm a head neck guy, so we're going to be talking mainly in the head neck area. Of course, we'll go to skull base, we'll go to the orbit intracranial part, and some isolated sites also that we've been seeing in our series. And also what has been our experience in the last 1.5 months, as you know, that's when it has hit us in Pune. And that's when our caseload has really gone up. So as far as imaging goes, now I have been following this particular 7-point imaging module, and it has really worked for me. It basically gives you some idea as to whether you're looking at a disease positive, disease negative category. And the 7 points, out of the 7 points, if you have 2 or more, according to this paper, which was actually authored by Tony Mancuso, it's very high specificity and PPV of patient having mucor. So what are those 7 points? We're going to see them in detail. It's peri-antral fat stranding, focal bone dehiscence, nasal soft tissue septal turbinate ulcerations and necrosis, orbit invasion, Pterygopalatine fossa extension, Nasolacrimal duct, and Lacrimal sac involvement. To this, I add a couple of signs that we see. So the best part of the 7-point imaging module is that it's all on CT, and sometimes even on plain non-contrast CT, where you cannot give contrast. Sometimes patient is diabetic, renal functions are impaired. You can't give contrast. Even plain CT can give you answers. To that, I add something on MR. So we have something called as a black turbinate sign or a black mucosa sign, which is again supposed to be very specific for mucor. And coming to the last point, that is imaging, which people are talking about, is the nature of the secretions, because it depends at what stage you're imaging the patient, whether it's watery, fungal sludge, or soft tissue. We know that it's CT hyper because of certain salts and minerals. We know it's MRT2 hypo because of manganese and iron. But I don't think I have been giving too much of importance to these kind of findings in the present scenario when we're looking at acute invasive fungal sinusitis. This comes more into play for chronic and for the AFS. So CT, I would say, let's consider this as the first modality for imaging in an early clinical setting. And what you need to really pay attention is to these areas. This is what I mean by the retro-antral fat, and that is the premaxillary fat and the premaxillary space. That is very, very important here because the earlier signs of perisinus inflammation are going to be picked up in these areas. And these are the areas that connect to the infratemporal fossa. They connect to the masticator space, and the infection spreads from here to there. If you are giving contrast, you can definitely comment on the orbital and intracranial extension. And why I would say CT first, because MR, sometimes if you jump into it in a very inflammatory kind of situation, you have a risk of overestimating the pathology on MR. So let's start with the first point, that's retro-antral and premaxillary fat stranding and also bone dehiscence. So we know that the fungi travel along the vessels, and that gives rise to these focal dehiscences there, as you see on the anterior and posterior wall of the maxillary sinus. And if you were not doing that soft tissue windowing, you would be missing out on this early perisinus extension of the pathology there and there. So that is why viewing it on bone soft tissue windows is so important when you're doing CT scan. We also know that fungi can travel through intact bone. That's through vascular channels and through neurovascular channels. So even if you have an intact bone, you look at it here, you have the stranding here of the retro-antral fat. This is a clean, dark retro-antral fat here, and that is abnormal retro-antral fat. That is abnormal premaxillary fat there on this side also. And this is another very important sign that we have to pick up as early disease. Now, this is a patient, in fact, we have just done 2 days back, and I do believe that we were looking at probably the earliest sign that we can see on CT scan, which is nasal soft tissue necrosis, septal ulceration. Can you see this ulcerated surface of the septum, and necrosis of the middle turbinate? We know that the disease starts in the middle turbinate. So if you're seeing necrosis in the middle turbinate, that's a normal middle turbinate on the right side, that's a necrosed middle turbinate on the left side. And when you give contrast, there is focal soft tissue loss. This area does not enhance. Under perfusion of tissue, we are going to take this the patient up for an endoscopic biopsy. And if this comes through, I think we are looking at a very, very early sign of mucormycosis. Orbit invasion. This can be through 2 methods. One is through the floor of the orbit, that is through the canal for the infraorbital nerve. You can see a normal canal here, and you see that the canal here is destroyed, it's eroded, and that is how this disease from the sinus is going to spread into the floor of the orbit and going to involve the inferior rectus muscle. The same patient again, you can see that's the break, that's the infraorbital nerve that is enhancing, and that is the inferior rectus muscle with intraorbital extension, as you can see also on the MRI, a bulky inferior rectus muscle. Many times we also get this break in the floor of the sinus, and then we just distend the oral cavity with positive contrast, and we can actually at the same sitting demonstrate that the patient also had a oral antral fistula on that side, which is also common in fungal infections. The second way it can happen is through a break in the lamina papyracea. So this is a very clear-cut break. We have a CT here. Already you have disease here, and it has gone into the floor on the right side. You have a break in the sinus, in the lamina papyracea here, and you have disease in the medial and superior compartment of the orbit. Now, where MR comes into play is when you're looking at very early intraorbital extension. So this dark line you see is the periosteum of the bone there, which shows a focal deficit here. And this is very early intraorbital extension of the pathology here. Here also there is a break in the line, and that's your intraorbital extension. So it can either come from the floor or it can come from the medial wall. The Pterygopalatine fossa involvement is extremely important. Why? Because all the abnormalities happening in the nasal cavity. You have something called as a sphenopalatine foramen here, through which pass the posterior superior nasal nerves. And we know that fungus or invasive mucor catches the nerves. So from the nasal cavity, getting through the sphenopalatine fossa foramen into the pterygopalatine foramen there, fossa there, and then from there into the pterygomaxillary fissure and infratemporal fossa is a very easy form of spread of mucor. So CT again picks it up very nicely here. Of course, the bone is destroyed. MR will be able to pick it up in a far early stage. Can you see the normal fat in the left pterygopalatine fossa? And that is obliterated here on the right side, and that is enhancing this early spread from the nasal cavity, necrotic tissue there, and that is early spread to the pterygopalatine fossa and from the pterygomaxillary fissure into the infratemporal fossa. The nasolacrimal duct and the nasolacrimal sac, we should check every single case, because most of the times I see on my referral forms is the patient is complaining of watering of the eyes. So you look at the area of the nasoorbital fold there and look at the normal nasolacrimal duct there, and that is infiltrated by disease. Again, large soft tissue necrosis in the nose, enhancing ulcerated surface. Again, the lacrimal sac is involved and the beginning of the nasolacrimal duct is infiltrated. So if you put together these 7 points in each of your CT scan and more than 2 are positive, you're looking at a pretty good chance that you're looking at a disease positive category. Coming to MR, Okay, so this black turbinate sign, that it has been described, not over 10 years that this sign has been described. We've moved on from a black turbinate sign to a black mucosal lining sign too. So what does that mean? Basically, it means non-vital mucosa overlying the nasal septum. Can you see a normal enhancement of the septum on the left side? And you see this dark area, that is non-vital mucosa. And you can see that part of the nasal turbinate here is enhancing. That part is not enhancing. These again are signs. Sometimes, of course, this is now an extensive disease. It's gone intracranial, but many times just non-enhancing mucosa of the turbinates or non-enhancing mucosa of the septum can give you an idea that you're looking at mucord. This, of course, is very, very florid. All the left side turbinates enhance well. All of these look dark. There is a nice break there in the cortical continuity of the mucosal lining. This is mucosal necrosis there of the maxillary sinus, and of course extensive disease also involving the masticator space and the infratemporal fossa. This is really not at what stage you should be picking up the disease. You should be picking it up at a much earlier stage. And this, of course, is even worse. Now the mucosa is completely destroyed. In fact, it is completely denuded and also reaches the bony margin of the sinus. So early detection, I would say here for a black turbinate or a black mucosa sign, it is important and it has relevance if you're picking it up early. In a late stage, you are anyways going to see it. In fact, many times we see that the extraocular muscles also don't enhance because of underperfused tissue. Now, I know I'm talking to a neurology crowd, which is why I'm just spending one slide on the intracranial complications, because as a head neck person, I know that you know much more about the neuro part than I do, but still I will just quickly try and cover the main things that we see in the neuro side. And that's first thing is just a simple 3D flare sequence is very good to pick up abnormal signal in the optic nerve. As you can see here, that's optic neuritis, inflammation of the optic nerve. That's your extension of the disease into the cavernous sinus. That's your cavernous sinus thrombosis. So patient will present with all your diplopia, ptosis, etc. And this was another case which we have done very recently, extension to the cavernous sinus. And you can see here very nicely this intimal thickening and intimal enhancement of the cavernous segment of the left of your right internal carotid artery. And that's what's the arthritis that is later on going to give infarcts. So all these cases, even though it comes for a PNS or for an orbit, we screen the brain, we take a diffusion sequence, and we do mention whether there are any acute infarcts happening or not. We are also seeing meningitis. We've seen subdural empyemas, cerebritis, cerebral abscesses, SAH, cortical venous thrombosis leading to venous infarcts, and of course, multiple cranial nerve involvement, which will give the same picture as we are seeing on the optic nerve, bright on flare, thickened and enhancing on post-contrast. So just to end my talk with a few slides is, our experience has been, we are seeing a lot of orbital apex involvement, sometimes with disease in other places, but sometimes maybe just isolated in the orbital apex. And from the feedback I get from the ENT surgeons, and I happen to be married to one, is that this is probably because they are seeing more disease in posterior ethmoid sinuses and related to the Onodi cell. So as in an Indian population, at least 30 to 33% of the Indian population has an Onodi cell. And if you have an infection in the Onodi cell, it instantly jumps onto the orbital apex and the optic nerve. The second thing that we are seeing here is osteonecrosis. So another case where the heart parieto was completely devitalized and dark there. That is a completely devascularized bone, which is dark. Other bone would normally enhance like this, and this looks really dark. And the finding that we have seen on CT is that you get these small air loculi within this devitalized bone. Skull-based osteomyelitis again can be there with a patient of known mucormycosis, as we are seeing here. This was a patient who had mucormycosis, came to us as a follow-up scan. And what we see here is again that same permeative osteolysis of the skull base on the left side. We see the scattered air loculi within the bone. And again, on the contrast MR, we see this large devitalized bone, completely dead bone with pachymeningeal thickening and enhancement. Many times we have also seen, as we have seen this particular case here, I would like to show it because it's a very florid case of skull-based permeative osteolysis. Again, similar picture, but this patient was COVID negative. So one has to also consider that probably this may have infected earlier, or we are looking at skull-based osteomyelitis, which has been indolent for a while. There is a category of mucor, which is a chronic indolent kind of mucormycosis, and that can last over a long time, and probably the patient at some stage had the infection and now is presenting with this situation, but we are not sure whether this is COVID or not. But because it was showing the similar kind of picture that we have seen in patients with skull-based mucor, I thought I would just show it here and share this with you. The other thing that we are seeing is many times what we consider as typical findings are not coming up on these stains. And at times they have pursued, because the ENT surgeon had a very strong suspicion of mucor, pursued it further, and on histopath, actually the tissue showed the fungus. Many times we have seen non-specific findings, which I would say this doesn't look like mucor to me, based on my 7-point imaging module, has turned out to be fungus. So we are still on that kind of curve where we are seeing new things every day, and basically still trying to gauge our reports. The conclusion of this particular talk, it's been a short and small talk, I hope, is more for my radiology colleagues. I do hope some of them are here to see the people who are attached to large centers and large hospitals who are doing a lot of work. Your report has to be situational. You cannot isolate an imaging study and report it. You have to be very clear about the background. You need to know all the clinical details. You need to pick up the phone and talk to the referring doctor, talk to the other consultants who are related in the care of that patient, and then give your report. Every report has to be situational. Our learning in this particular field, in this particular area of post-COVID mucor, is experiential. We are learning on the job. If we are diagnosing mucor confidently on imaging, I think we have missed the bus. We are already too late, right? We are not going to be in that position where we are diagnosing mucor when it's at a late stage. Then all we can contribute is to the extent. We are going to have to pick it up early. So we have to pick up those early pointers, raise the red flags in a relevant clinical setting. One thing I wanted to say, because we have ENT surgeons also on board, is imaging cannot differentiate active residual disease from post-operative reactionary mucosa after debridement. So we have to keep that in mind when we are reporting post-operative scans. And my last conclusion of this talk today is for my clinical colleagues. Please remember, we are radiologists. We are not microbiologists. We are not pathologists. We are trying our level best to help and contribute to the care of your patients. But sometimes we do feel the pressure, and at times we are not really able to give a histopathological diagnosis. And thank you very much for your kind attention.
Thank you, Dr. Wade. That was fascinating. And the number of pictures that you have, I think you have enough material to write a textbook on mucormycosis now. It's just incredible how beautiful those films are. Let's go on to the third speaker on the management. He's going to be concentrating on the medical management of mucormycosis in the setting of COVID. Dr. Sanjay Pujari is the Director and Chief Consultant, the Institute of Infectious Diseases in Pune. Once again, please keep your comments as brief as possible, so we will have some time for discussion. Dr. Pujari. We can't hear you. You're muted, Dr. Pujari.
Okay, am I audible now?
Yes.
Yeah, thank you for the organization for inviting me. As we all know, this is an emerging problem. We are seeing clusters of this disease, but unfortunately, as far as management of mucor is concerned, we are still developing an experience related to managing mucor in this setting, though we have some experience and there is a literature available. for management of mucor at a global level. So this is the outline of my presentation. I'll talk about principles of management of mucormycosis. We'll briefly discuss antifungals and finally discuss management guidelines and possible approach that we can use in India for managing mucormycosis in terms of the limitations of the drugs which are there. Very simply, mucormycosis, the important principle of management is we need a combination of antifungals with surgical management, which is aggressive surgical debridement, as well as managing underlying risk factor, particularly in this context, it is diabetes or steroid use or lowering the level of immunosuppression, which is as critical as the use of antifungals and surgical management. And this is a study which actually is one of the old studies, but it has a case study of almost included patients, almost of 900 patients. And as you see here, if you don't do anything, mucor mortality is very high, around 97%. And if you use only antifungals, you're going to have some amount of benefit. But if you use surgery with antifungal, that is where you see maximum benefit associated with management of mucormycosis. And this is the same Patel study that Rahul showed. This is a survival in mucormycosis in India, where they showed, of course, this is a heterogeneous population, multiple kinds of mucormycosis apart from rhinocerebral or rhino-orbital. And they overall saw a mortality of around 52%. But this was something, survival probability was better if you use medical plus surgical versus medical management alone. The issue is when to initiate antifungals in this context. In the COVID-19 scenario, this is our experience that mostly what we see is post-COVID-19, around 10 to 15 days of recovery from actual COVID infection. But of course, we can also simultaneously see mucor in the context of acute COVID-19 infection. Another important issue we have found in our practice is patients continue to be on steroids, often high doses, even after discharge for a long duration of time. And when they go home, they have this diabetes being not monitored. They have uncontrolled diabetes simultaneously, or they may have steroid-induced hyperglycemia, which is not monitored at all. And the management is discontinued. This monitoring and management of diabetes is kind of neglected once they go home. Usually, the commonest involvement is sino-orbital, and occasionally we have seen cerebral involvement, but of course, data is evolving. You have to remember that this is a medical emergency and early initiation is strongly recommended. The issue about why mucor is happening, I personally believe is predominantly diabetics. As Rahul showed you, 100% of his patients had hyperglycemia. And the way by which we are seeing most common form of mucormycosis is actually rhinocerebral sinus or sino-orbital, which is common in diabetics. And we have still not seen pulmonary mucormycosis in our series. But in malignancy, you predominantly have pulmonary. So it looks like the host factor, which is also demonstrating the presentation of mostly rhino-orbital or sino-orbital and cerebral involvement, suggests that diabetes should be one of the major risk factors that is leading to this, or hyperglycemia, if I can say, along with maybe steroids, maybe the most important risk factors. Why should you try to start treatment early is because this study, of course, mucor studies are always limited by small sample sizes. But if you start treatment early, you have higher probability of survival, and early treatment is within 6 days of symptom onset versus the delayed treatment. So early treatment is key. It's a medical emergency and needs to be diagnosed early, as Dr. Vaid told you, and also something which needs to be initiated very early. A brief review of antifungals. We have these two major groups of agents which are used in mucor. You have the polyene group, amphotericin B, both conventional deoxycholate, as well as lipid formulations like liposomal amphotericin B and amphotericin B lipid complex. And amongst the azoles, we have these newer azoles, posaconazole and isavuconazole, which basically are used for treatment of mucor. Now, we all know that deoxycholate amphotericin B is something which is widely available in India. It is cheap, but for the treatment of mucormycosis, all data that is available about its efficacy and safety is before the availability of the lipid formulations. During that time, high doses of conventional amphotericin B were used, around 1 to 1.5 milligram per kilogram per day. Unfortunately, there is no head-to-head comparison of using conventional versus lipid preparations for Mucor. There's a perception that probably it is less effective than liposomal amphotericin B. But if you look at this large meta-analysis, which was published in 2017 for efficacy in invasive fungal infections across all lipid formulations of amphotericin B, the efficacy was really not different between conventional amphotericin B and lipid formulations of amphotericin B. And this is another study which looking at risk factors for mortality. I would like you to focus on these two things. You see both with deoxycholate as well as lipid amphotericin B, the mortality odds was lower with either of these drugs that has been used. But again, this is a Patel study from India, and they did a Cox regression analysis. And what you see here is the deoxycholate preparation was associated with the two-fold higher hazard of mortality as compared to no treatment, versus liposomal amphotericin B was not associated with the hazard significantly. So there may be some signal, but not sure about the robustness of the evidence to suggest that maybe deoxycholate may be less effective, but that is something which is not really proven robustly by studies. The major disadvantage obviously is toxicity. We have all used deoxycholate amphotericin B. It can cause infusion reactions and has a higher risk of nephrotoxicity, particularly when you're using more than conventional dose, 1 milligram per kilogram per day, and if you have concomitant nephrotoxic medications. We all know that sodium loading prior to giving amphotericin B would ameliorate the decline in the GFR and perhaps prevent or reduce the risk of nephrotoxicity. Because of tubular involvement, you have hypokalemia, hypomagnesemia, making it important to monitor this and correct this repeatedly. This is the statement of the global guidelines from the European and the mycosis study group. What they mention is that deoxycholate amphotericin B has been a drug of choice for decades for treatment of Mucor. It is effective, but its use is limited by toxicities for the dose and duration that we are going to use it in Mucor. So its use is restricted only in settings where no other antifungal therapy is available. So keep this in mind. Liposomal amphotericin B, we all know, is basically a vehicle delivering amphotericin B. The risk of nephrotoxicity is lower. It basically concentrates at sites with the fungal infection and actually avoids getting into the kidneys. High dose liposomal amphotericin B for mucormycosis. Now again, these are very small studies, single arm studies. And what they demonstrated that in these patients who used more than 7.5 milligram per kilogram of liposomal amphotericin B for treatment of Mucor, the risk of the recovery was higher around week 4, almost 40 to 50%, I think, patients recovered in this study. But of course, nephrotoxicity is an issue, and this is a meta-analysis looking at comparing both of this in invasive fungal infections from the previous study, which showed no difference in efficacy. Conventional amphotericin B obviously is higher, associated with higher nephrotoxicity as compared to lipids, and so is the issue of fever and rigors, nausea, vomiting. These are the events which are more common with conventional amphotericin B as compared to lipid amphotericin. The azoles for mucormycosis are now posaconazole. Basically, initially in India also it was available as an oral suspension. We knew it has a very poor bioavailability and needs to be taken with high fat meal. But fortunately now we have the delayed release tablets which are available. We have to remember that the IV formulation has cyclodextrin, and this is something which is also there in remdesivir, if you remember. And this cyclodextrin molecule can get accumulated in the context of low creatinine, but studies have really not shown a higher risk of renal toxicity associated because of that, particularly if they're not used for a longer period of time. The tablets have less variability in PK with food. There are drug-drug interactions because it is metabolized by the 3A4 pathway, and we have anti-epileptics, etc. Those are also mediated through this. And it also has a very rare unknown kind of amount of risk. We clearly don't know how much, but interfering like ketoconazole with the steroid synthesis pathway, leading to adrenal insufficiency. Isavuconazole is also a newer generation azole. It's a prodrug actually, isavuconazole sulfate. It has a large volume of distribution, has high degree of tissue penetration. Its IV does not contain cyclodextrin. And also clearance is dependent on 3A4. So you need to monitor for DDIs. Now the data for use of these azoles in mucormycosis is very, very sketchy. The sample sizes are very small. This is one MUON study where they looked at actually matching from registry of the Fungiscope. There's a big registry called the Fungiscope registry, in which they could demonstrate that posaconazole newer formulation had a higher survival probability as compared to amphotericin B. But this is largely based on just 5 patients in this group. So we can't really make conclusions about its efficacy from such a study. Isavuconazole use is also again a single arm study in about very low number of patients, and historically controlled with amphotericin B patients receiving. So it was not concurrent controls, just 21 patients, and they could demonstrate similar survival probability when it is used as primary initial treatment or for salvage treatment. Salvage treatment in mucor is defined as somebody who has progressive disease or is unable to take amphotericin B because of toxicity. Ion chelation is an interesting concept, and this is again a small study, but a randomized control trial looking at using deferoxyrox plus liposomal amphotericin B versus placebo, and actually they had higher mortality in the deferoxyrox group as compared to the placebo. So that is something which is quite in a limbo now. So finally, let us look at how do we approach this. And currently there is one global guideline which is something which is interesting to really follow. So this is a patient. This is a situation where liposomal amphotericin B is available. Now you see here in this suspected or confirmed mucor, surgical debridement and immediate treatment initiation is recommended. The preference is to liposomal amphotericin B 5 to 10 milligram per kilogram from day 1 without escalation of doses. So slow escalation is not recommended. You have to initially start it with full dose. If there is brain involvement, then 10 milligram per kilogram per day of liposomal is something which is recommended. So this is predominantly strongly recommended when liposomal amphotericin B is available. These guidelines recommend not to use conventional amphotericin B. Once the patient is on this, you do response assessment, and that is along with clinical or maybe repeated surgical debridements and looking at microbiology, doing weekly imaging. If you find that the patient has stable disease or that has partial response, you can try to continue the first line treatment if the patient is tolerating, or change to step down oral treatment. You can use either posaconazole tablets or isavuconazole tablets in these doses. If there is progressive disease, normally on amphotericin B, there are should be managed on a case-to-case basis, but they recommend to switch to another class. So you go to the IV isavuconazole or IV posaconazole in this context. If liposomal amphotericin B is unavailable, then again surgical debridement and immediate treatment initiation. And the recommendation for them is giving isavuconazole IV or posaconazole IV until patient achieves a stable disease, and subsequently stepping it down to oral treatment. Again, they do not recommend amphotericin B deoxycholate in this context. But this is something which is difficult in our context. As Rahul has already mentioned, we have problems with availability, etc. So this is a possible approach for antifungal therapy based on whatever evidence is available. I think the preferred treatment obviously is liposomal amphotericin B 5 milligram per kilogram in the absence of CNS disease, but 10 milligram per kilogram for CNS disease. If it is unavailable, we would use deoxycholate amphotericin B 1 milligram per kilogram or IV posaconazole or isaconazole if those are available, but of course those are expensive. Once the patient is improving or has stable disease, you step down to oral posaconazole. This dosing is very important, initial 1 day and 2 days, where you need to really load and then subsequently keep the maintenance dose. And finally, it is very important to measure a posaconazole level around day 7, day 3 to 7 to achieve a target of more than 1 microgram per ml. So therapeutic drug monitoring is very important for posaconazole and the role of therapeutic drug monitoring in isavuconazole is still not really researched well. What is the duration of treatment for mucormycosis? The ideal duration for treatment is unknown. It usually goes from weeks to months. These treatments are needed. Normally, you would do IV treatment until stable disease is achieved and then step down to oral ones. The recommendation is to avoid posaconazole suspension unless there is non-availability of the tablets because of its variable bioavailability. And its therapy is continued till, this is what is recommended by the European group, underlying risk factor has to be controlled. And in this, most of our patients, diabetes, ketoacidosis, stopping steroids. Complete substantial radiological resolution should be achieved, either complete or substantial radiological resolution. But as Dr. Vaid mentioned, it's difficult to differentiate the changes from post-surgical changes. So we have to be trying to be on case-to-case basis, individualized, correlated with the clinical response. Usually this goes on for around 3 to 6 months in the absence of the COVID scenario. Of course, we should probably look at treating for the same duration in patients in the post-COVID scenario. Is there a role for prophylaxis or combination therapy? For prophylaxis, the recommendation is only in special population. We're not talking about the COVID situation, but in GVHD and neutropenic patients. And there is no convincing evidence for initiating prophylaxis for any other patient group. As far as combination therapy is concerned, it's not recommended routinely, maybe on a case-to-case basis, but particularly after a consult, if there is rapid progression, you may think of initiating combination azole with amphotericin B. So in summary, the importance aspect of treatment of mucormycosis is early surgical excision of necrotic lesions, correcting underlying risk factor and antifungal therapy. Immediate initiation of antifungal treatment is absolutely critical. I showed you that data which essentially says that you should be initiating it within a week of symptom onset. It's a team effort. It includes medical, ID, surgical, radiology, and microbiological teams that all need to work together in coherence. But I think the key message at this point of time is for prevention. And this is one aspect that I have been telling people in my talks, that steroid use in COVID-19 has to be done in the right patient at the right time, in the right dose for the right duration. This is very, very critical. And I think this is something which has perhaps contributed significantly, either directly due to immunosuppression or because of exaggerating hyperglycemia in our context to these large number of cases that we are seeing. So monitor and manage hyperglycemia efficiently. We usually get obsessed with treating COVID-19 and often forget managing comorbidities. They're as important or perhaps more important than managing COVID-19. I think that's all. I did a very brief talk and would like to, happy to answer any questions.
Thank you, Dr. Pujari. I think the most important message, as far as I can see, is the use of steroids. Please be very, very careful, discriminately using steroids and not giving excessive doses for long periods of time. This is the best known culprit for precipitating mucormycosis, particularly in the setting of hyperglycemia. Let's move on to the last. Before I go to the last speaker, I'm looking at my clock here. It's 7:42. As per the schedule, we have about 18 minutes left to have surgical sorry?
Dr. Chandrasekar, we can extend by 30 minutes, so no worries.
Okay, very good. Thank you. That's what I was going to ask. Okay, so we have a little time. So we're going to go on to the last talk of this evening, the surgical aspects in the management of mucormycosis in the setting of COVID. This is very critical, as mucormycosis patients need frequent surgery and frequent debridements. very disfiguring surgeries. Let's hear this from Dr. Pushkar Gadre, who is a consultant oral and maxillofacial surgeon in Pune Hospital in Pune. Dr. Gadre.
Thank you, one and all. On the onset, it's a brewing war which has come up with, for all of us, which is a new frontier, which is known as CAM, a corona-associated mucormycosis. What we like to know about mucormycosis till date, that is, it mimics the signs and symptoms of a pathogenic infection. But at the same time, it doesn't respond to the antibiotics. And the progress of the disease is very fast. Mortality in the worldwide literature is approximately 50% if it's not treated promptly and correctly. A new frontier has arisen because of COVID-19. And add on than that, the burden of sheer number of burden of patients of COVID-19 itself is causing an ignorance from the healthcare workers towards CAM. And also contributing is unawareness of the CAM and its complications. Further immunosuppressants, as rightly said by Dr. Pujari sir, regarding use of steroids and an unpredictable surgical as well as the outcome of the disease. It's a traumatic and mutilating surgery. It is impossible to reconstruct, because until and unless the infection is settled, we cannot reconstruct. We have to keep that area open or raw. It's a physiological and psychological trauma to the patient. It's a burden because already the patient has spent a lot of time in the hospital. There is a burden of financial on the patients because of the reasons being he has already been admitted for COVID-19, and on top of that, further admission is required for mucormycosis. The surgical treatment depends upon which part or organ which is affected. In general, the presentations, following are the presentations which are seen. I'm showing this because a lot of healthcare workers are also in this seminar who would like to know what are the clinical signs and symptoms of mucormycosis or how the patient comes up. In general, the patient is having a COVID history, fever, malaise, headache, swelling, pain in facial region, skin necrosis, and gangrene are seen in extreme cases. Rhinosinus are nasal stuffiness, blockage, discharge, fullness over sinuses, and anosmia. These are a few symptoms which are seen. The orbital symptoms, the nasal discharge. There is a blackening or gangrenous of the skin or necrosis of the skin. This is also cutaneous presentation of mucormycosis. Further speaking, orbital presentation are ptosis, proptosis, chemosis, reduction, reduced burning or loss of vision, ophthalmoplegia, ophthalmalgia, epiphora. In dentoalveolar, it's pus discharge from the gums, mobile teeth, halitosis, non-healing socket, necrosis of mucosa. Here are a few presentations. Ptosis, chemosis of the eye with periorbital ecchymosis is also present. There is reduction or no movement of the rectus muscles and the eyeball. Here in dentoalveolar presentation, this is early abscess or just sinus formation, which might result into fistula. In late early stages, you see necrotic mucosa of the oral cavity, predominantly in the maxilla. Further, there is necrosis or gangrene of the maxillary mucosa, and here the bone gets exposed. These are also the features which are seen: a fistulous tract, a necrotic bone, abscesses over the gums. I have come across many cases of lower jaw also. Approximately 10 to 15 mucormycosis cases of lower jaw also have been experienced. I have seen. There is also osteonecrosis of the jaw, even if there might be presence of mucor or no. is also seen post-COVID. Diagnosis, imaging, as already said by sir, there is a high, I won't cover this part. Thereafter is biopsy can be done by Carvel or FES. FES is a better choice than Carvel. But in case it's limited to the maxillary sinus, we can go ahead with the Carvel. Gram staining, AFB staining, KOH mount, fungal culture, the tissue has to be sent for. Few radiological presentation. This is a dental presentation where you see a necrotic bone in the maxilla, the mandible, the sinus is full, and the MRI presentation. Ved sir has already covered the topic. A successful management depends upon following things. High suspicion index when no response to antibiotics. So you have to catch them early. Early detection, early treatment gives a favorable outcome. Reversal of underlying predisposing factor is also required. For this, our physician and neurologist friends also help a lot. Prompt and radical surgical debridement. Mind you, the radical surgical debridement, which I insist upon, rather than going for a conservative approach. First, to clear ethmoid and sphenoid, it depends upon which area or which part of the head and neck the mucor is seen. Cardwell luck for maxillary sinus clearance, extraction of multiple teeth, saucerization, curettage of involved bones till vascular bed is reached. Why do we require our vascular bed in this mucormycosis treatment? Is because the drug delivery is induced by the newer vessels or angiogenesis in that area. Unless and until you debride or you remove the necrotic area, there won't be any new vascularization, and the blood and the drug won't reach over there. Administration, this active debulking or saucerization or curettage or debridement also helps in reduction of fungal load. This is also a critical point while treating mucormycosis surgically. Administration of active fungal agents, prompt and radical surgical deployment, as per suggested, are maxillectomies or mandibulectomies, in which we have found out there is a maxilla or mandibular involvement. Zygomectomies, infratemporal clearance. In seldom cases, the muscles also get necrosed. I've come up across many cases in which the temporalis and the masseters, zygomaticus major, have been affected a lot. Palatectomy, eyeball exenterations. Unfortunately, I have come across most of, in the second wave, most of the patients are presenting with orbital symptoms in early stages itself. And I have come across patients who required, or I have done, or I have performed the eyeball exenterations in 30 years old or 35 years old also. Orbital decompression, this can be done with FES. Soft tissue debridement is also seldom required. Saucerization and curettage of involved bone till a vascular bed is reached. Exenteration and not evisceration of the eye if ophthalmoplegia, loss of vision, retrobulbar fat, strangulation, or breach in orbital wall is seen is proposed. Because exenteration leaves no tissue behind, which might be affected with fungus. Administration of active lyophilized amphotericin B, Dr. Pujari sir has already spoken about the same. The successful management also depends upon good and pursuing nursing care, adequate and appropriate nutrition, vigorous follow-ups by clinical examination and imaging, maintaining high suspicious index for relapse or recurrence, managing host-based risk factors like diabetes or underlying causes, psychological counseling. Most of my patients, I send them for psychiatric counseling also before rehabilitating them. Plan for delayed rehabilitation, facial or dental, both can be achieved. Points to ponder upon. It's a multidisciplinary approach. FES can be useful for diagnosis and curative only in early mucosal disease. But you have to be radical if the disease has gone beyond it. We have come across osteonecrosis of the bone, head and neck bone, which is one of the most vascular bone. But at the same time, in these conditions, we require a surgical maxillectomies or mandibulectomies, zygomectomies, depending upon the case. Average time to mucor post-COVID recoveries was 3.3 in the first wave, which has shortened in the second wave. I've been operating positive patients on a daily basis because in active COVIDs, we are seeing mucormycosis frequently. Open biopsy is recommended as false negative reports may come with swabs. Rapid transformation of osteomyelitis making phase ineffective was also seen. Multiple phase cause delayed in the radical treatment and may result in poor outcome. And this is my face, my ENT colleague had done this. In this picture, you can see the necrotic tissue or the mucosa. This is the maxillectomy specimen in which the maxilla was removed. You can see this picture I'm particularly pointing out because you can see that I had done the eyeball exentration, and at the apex you can see the blackening coloring, or the base of the skull you can see the blackening, which is the presence of the mucor. And after clearing it out, this is the picture which is seen. This is the exentration specimen. In early maxillectomies, you can see the maxillary involvement. Here you can see the mandibular involvement. You can clear out without disfiguring the patient by doing the intraoral approach for the orbit also. If you have a good approach intraorally, you can clear off ethmoids also intraoral approach. This is the floor of the orbit. The zygoma can be reached laterally also. But in certain cases, it's much more mutilating. In this, there is necrosis of the skin. Unfortunately, this patient had infratemporal space involvement also, with pustules forming in the temporalis area. This is the eyeball exenterations. Points to point upon is a radical approach akin to malignancy. See, in this, it has to be treated like a malignancy, but no margin is required. When you have a good vascular bed, the amphotericin or whatever drug of choice is yours that reaches over there. I believe in one shot, radical surgery has the best outcome. If you have to do multiple times surgery, it might result in unfavorable outcome, because the patient has to bear the cost of it. One, the patient mindset changes. Two, the patient is financially drained out. Three, and the use of antifungal increases thereafter. During second wave, we have seen orbital involvement on a rise. Amphotericin duration and dose is determined by my physician colleagues and friends. Coming across 84 cases treated during COVID wave with a multidisciplinary approach, out of which 85% have got a success rate in one-shot surgeries in treatment of mucormycosis. This is due to my physician friends, ENT surgeons who work with me, radiologists, neurophysicians, psychiatrists, resident doctors, nursing staff, ward helpers, and prosthodontists. All is not lost. It can be gained again. This is one of the patients treated for mucor. I had to do an exentration, left maxillectomy. There was a fistula present thereafter. I put in for reconstruction supraorbital implants, one zygomatic implant, and 3 regular implants. And his appearance has changed. You can make it. It's a fixed prosthesis which I've given. So if you can be a destructor, you can be a destructor, and you can be a creator for the same person. Here you can see the reconstruction done for maxillectomy, bilateral maxillectomy for mucormycosis, reconstructed after 3 months with zygoma implants and his post-op results. Thank you for patient hearing.
Another 2-week period. Dr. Mishra?
Yeah. Dr. Chandrasekar.
Sorry. Am I audible now?
Yes, sir. Yes.
Okay, thank you. I just started saying that thank you to all the 4 speakers. That was a very good description of the clinical, radiological, and the medical surgical management of mucormycosis in the setting of COVID. I had a few slides, but we have about half an hour. Let me show you the 3 or 4 slides that I have, and then we'll go on to the question and answer session. If somebody would be kind enough to project my slides.
Mansi, please project the slides. And after your presentation, then we can have comments from Dr. Vikram Oak, who is the ENT specialist.
Okay, will do. Most of what I had thought of bringing it up have been already said, so I could be very brief. As you know, as the slides are coming up, let me start my comments. I'm an infectious disease specialist. I have a great deal of interest of infections in the Indian subcontinent. So over the last 30 years, we know that there is plenty of mucormycosis in India. In fact, some people would call it the capital of mucormycosis. So mucor is not new in India. All of you have seen these cases, but most of the cases are seen in patients with uncontrolled diabetic patients in ketoacidosis or very hyperglycemic states. Whereas in the United States, we do not have diabetics in such poorly controlled states in large numbers. So mucor in this country is primarily seen in cancer patients and transplant patients who are highly immunocompromised. Whereas in India, most of the cases are seen in the diabetic setting, and of course in the immunocompromised setting as well. Now, within the diabetic background, with COVID and steroid use, it has become a perfect storm, vastly exaggerating the number of cases of mucor in the setting of COVID. Could I have the first slide, or slides are not available?
No, she got disconnected. She's trying to connect again. Just
okay. So, as far as the management of mucor is concerned, as Dr. Pujari said, it's early diagnosis, early diagnosis, early diagnosis. And Dr. Kulkarni went over the various features of early diagnosis. In this context, in the setting of the pandemic, patients who are complaining of numbness or patients who are complaining of persistent headache, certainly the entity should be thought of and appropriate testing has to be done. And then, of course, we can make the diagnosis right away with appropriate imaging and early endoscopic surgery for staining and for histopathology of the tissue. The treatment, amphotericin remains the drug of choice. As Dr. Pujari said, liposomal amphotericin would be preferred, but again, there is huge financial constraints, not allowing many of the Indian physicians or many of the Indian patients cannot afford the liposomal formulation. There is no data to say that conventional amphotericin B or deoxycholate amphotericin B is inferior. The efficacy seems same. However, the toxicities are vastly different. So if somebody can afford, then certainly liposomal amphotericin B would be the way to go. As far as the azoles are concerned, both posaconazole and isavuconazole seem to have some activity with limited data. However, the important point to remember, mucor has multiple species. Some of the species are susceptible to amphotericin B and some are not. Some of the species are susceptible to posaconazole and many are not. So many of the pathologists or microbiologists, after saying this looks like mucor based on the morphology, they are unable to speciate and give us the exact species. So without exact species, you may not be able to tell if the azole or the polyene is going to be working. So ideally, you would like to have exact, okay, Can you see my slides?
Yes.
Yes, sir.
Okay, very good, very good. So I just started talking about the epidemiology of fungal infections. As you can see with COVID, there are 5 different types of fungi that have been associated. COVID-associated Aspergillus, Candida auris, Mucormycosis, where most of the reports are from India, Pneumocystis, and reactivation of endemic mycoses such as histo, blasto, and coccidioidomycosis. Aspergillosis seems to be the most common fungus, and very frequently it followed viral infections like influenza in the past, seems to follow the same line with COVID as well. However, Aspergillus is a very common colonizer in the pulmonary tree, so it becomes a challenge to distinguish colonization from infection. Biomarkers that we use are galactomannan and beta-D-glucan. Bronchoscopy is a challenge because you would aerosolize the respiratory secretions, further spreading the COVID. So bronchoscopy is contraindicated in such patients. So the diagnosis is controversial to distinguish whether the Aspergillus that you recover from the pulmonary tree is true infection or colonization. As far as the clinical aspects are concerned, we talked about this already: indiscriminate use of steroids, diabetes mellitus, lymphopenia from the SARS-CoV-2. And again, it seems like COVID-19 by itself may be a risk factor, as there have been cases where there have been no steroid exposure, yet the patient goes on to develop these invasive fungal diseases. Next slide. Okay, this is the one I was talking about. Dr. Ravankar is a colleague of mine. In his lab, he had performed susceptibility testing with microbial inhibitory concentrations of various species of mucor. As you can see, they're quite widely different. This is for just posaconazole. Likewise, there are some preliminary data with isobuconazole as well. So ideally, one would like to have species identification before launching into the choice of drug, but species identification may not be available in most of the laboratories. So therefore, you would have to make an assumption that these organisms may be uniformly susceptible to both amphotericin B as well as azoles, including posaconazole and isobuconazole. Next slide. So the management, early suspicion of infection, these are non-classic hosts. So you have to think of mucormycosis either in the rhinocerebral setting or in the pulmonary setting. Please pay attention to steroids. Discourage primary care physicians from indiscriminate use of steroids and attempt to avoid empiricism. In the US, there is a ton of empiricism in the ICU. Patients are on antibacterial, antiviral, and antifungal drugs all at the same time, contributing to polypharmacy and incalculable amount of harm to the patient. I think I'm going to, as far as the drugs are concerned, one needs to be conscious about the availability, toxicity, cost as well. So those are my comments from the US perspective. Let's open it up for discussion now. May I invite all 4 speakers to—
We'll have, can we have comments from Dr. Vikram Oak?
Oh yes, I'm sorry, I overlooked that. Let me invite Dr. Vikram Oak at this time. He's an ENT surgeon for his comments on this topic. And after that, we will move on to the discussion. Dr. Oak?
Yeah, hello, am I audible?
Yes, you are.
Yeah, okay. I'll be very brief because we are running short of time. So I'll be just briefly talking about the surgical management of rhino-orbital mucormycosis. So basically, we can divide it into 3: sinonasal mucormycosis, which is limited to the nose and the paranasal sinuses; rhino-orbital mucormycosis; and rhino-orbital cerebral mucormycosis; and in some cases, dentoalveolar. So before COVID, we used to see very few number of patients, but now we are seeing 7 to 8 patients per week. Now, I would say that the early signs and symptoms which we can pick up on clinical examination, running nose, crust in the nasal cavity, and blanching of nasal mucosa. So before blackening of the nasal mucosa, which would be a slightly late sign, if we do an endoscopy at an early stage, and if we can pick up blanching of the mucosa, which is because of the blockage of the blood vessels, and take a biopsy, we can pick up mucor at a very, very early stage. And of course, peri-retroorbitary pain and swelling is there, facial numbness and pain is there, and headache is there. Early diagnosis, I would say, along with the radiological investigations, a nasal endoscopy could be very, very handy. Like I said, a good ENT surgeon putting an endoscope into the patient's nose and picking up blanching of the nasal mucosa and taking a biopsy and sending a swab or sending a biopsy for a calcofluor stain can pick up mucormycosis at a very, very early stage. Surgical plan, I would say, is to do surgical intervention as early as possible and to remove all visible disease. So when we do endoscopic sinus surgery, we have to do clearance of paranasal sinuses, removal of all the turbinates, removal of the nasal septum, and sometimes we do orbital decompression. In advanced cases, what we do is endoscopic sinus surgery. And in some patients, I would say around 20% patients, we have to do partial maxillectomy and orbital exentration. And many of the patients, we are doing endoscopic sinus surgery along with orbital decompression. I would say certain points about the endoscopic sinus surgery is we can tackle the entire disease in the sinuses, including the maxillary sinus. There is no need of doing a Calvin-Lux operation. In fact, what we are doing is a modified Calvin-Lux operation, which is called as a Denker's operation, where we enter the maxilla and then we have approach towards the Pterygopalatine fossa. So we have an end-on view of the Pterygopalatine fossa, and we can tackle the disease in the Pterygopalatine fossa. We use a Denker's approach, not a Calvin-Lux approach. And then, of course, partial maxillectomy, orbital exentration. Post-op care, I would say, is extremely important because it is not just the surgery and not just the medical treatment, but then a daily nasal endoscopy and suction clearance from the nasal and the sinus walls. Isotonic saline sprays, liquid paraffin as nasal drops we use very, very regularly, and a nasal wash or a nasal douche at least 2 to 3 times a day, I would say, and of course, a long-term follow-up of the patients. So I think in brief, I would say that early diagnosis by nasal endoscopy, aggressive surgical debridement combined with antifungal treatment is essential for getting better results. Thank you.
Thank you, Dr. Oak. Thank you for your comments.
Thank you.
There is some background
We got
disturbance.
50.
Sorry? Yeah, there is some background disturbance. Kindly mute your microphone. Thank you. Let's invite the 4 speakers.
You got 52 questions, sir. Can you take some of the questions?
Yes, we will take the questions. Kindly, the speakers feel free to answer the questions. Let me start with Dr. Kulkarni with your experience on the 121 cases. They are asking questions regarding, can patients present with rhino-orbital mucormycosis and COVID may have been diagnosed or may not have been diagnosed? Can that rhino-orbital mucor could be the initial presentation in this setting? Number 1. Number 2, are there situations where no steroids have patients been exposed to? Can patients develop mucor in the absence of steroids in your experience? And number 3, does pituitary get invaded during this setting? Have you ever seen these patients? I've just randomly selected some questions, trying to hit on some of the major areas. Dr. Kulkarni, Please be brief with your comments.
First, we have not seen anyone who has mucor as a presentation of the COVID. We had a couple of patients during this period who did not have history of COVID, and they had mucormycosis. Of course, their antibodies when they did not develop any COVID-related symptoms in the hospital stay. So COVID, we are not seen as a presenting feature of mucor. Usually it is seen during mucor or maybe after mucor, 40% during mucor, 60% after mucor, after COVID, sorry. And the average duration, about 15 days after the onset of COVID that we have seen mucor. That's one. Number two, there was a question on
steroids.
Steroids. In our series, the steroid use was there in about 92% of the patients. So there are about 8 to 10% patients who are not on steroids. We are trying to do a case control study to see what are the risk factors amongst the diabetics also. And then, of course, we know that the dose of steroid or maybe the type of steroids and the duration of steroid may matter. But again, we need some more data, clarity on the data on this issue. And
in patients who, patients who presented without exposure to steroids, are there any unique features?
Not as yet. We are still in the process of analyzing the data. The data is collected till 30th of April. So just last 1 week that we are analyzing the data. As yet, there is no other risk factor that has emerged of these patients.
Okay. Any pituitary invasion?
No pituitary as yet that we had seen. The disease has gone up to cavernous, but nothing in the pituitary as yet.
Okay. One of the postulates, one of the hypotheses is the oxygen delivering apparatus or the humidifying water may be contaminated with mucor, and hence the rhinocerebral presentation of mucor with easy access with the contaminated water. Have you looked at your water supply, the oxygen delivery tubes? Is it possible these could be contaminated?
Again, interesting hypothesis. One needs to do some basic research looking at the oxygen tubes, contaminators. The problem is amongst the cases that I had shown you, we had managed about 25 odd in our hospital. Of these, only 3 had developed mucor after COVID in our hospital. The rest 22 patients were referred from some other center. So patients were managed for COVID at some other centers, which are typically the built-in hospital for the COVID care, and maybe on the smaller centers. And from there, the patients were referred to the bigger hospital, to the neurologist, to the ENT specialist for the management of mucor. So there is this issue of managing at different centers. So we need to actually look at the humidifiers or the water at the center where the patients were managed.
Thank you. How about the other speakers?
Would anybody comment? Can I just add? We are seeing mucor even in individuals who have never taken oxygen. So they were mild illness, they were at home, they were given steroids, and subsequently they have developed mucor because their sugars were not controlled. So it's perhaps this needs to be looked at, but I think it's environmental exposure.
Right. I think so too. I think I'm afraid the hospitals have become houses for mucor. As we turn around these patients so quickly in large numbers, with and without mucor, it's quite possible that the hospital wards now are housing this organism, and in the appropriate setting, these patients inhale this organism. So infection control needs to play a very big role, both in investigating the hospitals, the hospital wards, and like you said, the oxygen delivery process and the water supply, etc. There are inordinate number of cases being reported from India in contrast to many other countries. For example, my hospital here, almost 2/3 of the hospital takes care of COVID patients. I am yet to see a single case of mucor. And we do use a lot of dexamethasone. Granted, we don't have as many diabetics as your hospital might have, but certainly steroid use is quite a lot. Our ICU guys love to use steroids for ARDS. So they don't follow the usual recovery trial dexamethasone. They use large doses of steroids for protracted periods of time. So I think infection control may have to step in here.
Can it be also because of the weather conditions, which are conducive to harbor mucor in India? And if you have seen, that has happened, that it's a mixed situation. where we are having a lot of rains and a lot of heat. It's a humidifying and dehumidifying climate in India at present.
Yes, absolutely. Soil-related fungal infections in India is quite common. Many of the farmers may bring the organism into the hospital. Certainly, yes. Environment both within the hospital and outside is conducive for these soil fungi.
And
So
maybe
that is
there are a lot of new construction because new COVID centers were built and the beds were added. That might have also contributed to the.
right. Absolutely.
And most of them are farmers. If you see, the large number are farmers which are having mucor, coming up with mucor.
Yes, yes. Let me go
Dr.
on to
Chandrasekar, may I make a comment here, please?
Yeah, please go ahead.
Dr. Katrak. If humidity and was a problem with mucormycosis, I think Mumbai should have had more cases than Pune, which has a more drier climate.
I don't think it's one single factor.
Yeah, that is what I mean. I don't think it's just one single factor.
Correct.
It's a multiple environmental factors.
Yeah.
And the fact that Pune drains more of the rural areas than Mumbai may be one of the factors that plays a role in the increased incidence of mucor in Pune compared to Mumbai. Although recently, I think there have been articles in the lay press which have mentioned the indiscriminate use of steroids playing a major role of mucormycosis in Mumbai.
Yes, I think this has been repeatedly said in this gathering already. I think if there is one single message, please don't use steroids indiscriminately. That's a clear risk factor. Let's move on from there and try to find out how come Indian hospitals have so many cases of mucor while COVID is rampant in other countries and we don't see it. I have a feeling that it may have something to do with the Indian hospitals' infection control. How cautiously are we looking at the devices being used on our patients, the hospital wards themselves, the beds, the linen, and the water supply, the oxygen delivery apparatus? How stringent are the infection control measures? Have they looked for persistent presence of organism long after the patients have left the wards, so that the next patient who comes in may be at risk? How good is the cleaning of these rooms between patients? These are simple but very important things that need to be looked into. Let me
May
go
I
on
make
to
a
some of the
comment on
questions.
that? No, may I make a comment on that? I'm Dr.
Very
Katrak
briefly,
again.
very
Yeah, very brief. I think first of all, we must accumulate the data from all over India. We are talking only of Maharashtra. I saw a remark by our secretary of the IAN, Dr. U. Meenakshi Sundaram, that he's not seeing a single case of mucormycosis in Chennai. So
Well,
I
let me interrupt you. I have several friends in Chennai. These are infectious disease colleagues. They are seeing plenty of cases of mucor.
So maybe we are not seeing neurological. We are not seeing neurological invasion in Chennai.
Okay, well, there are cases of mucormycosis. I'm in one of the WhatsApp groups. They're constantly discussing how rampant it is in Tamil Nadu, in Apollo Hospital, in Global Hospital, and a variety of other hospitals. And most of them seem to be mostly rhino-orbital presentation, not pulmonary presentation. Exactly. So let's move on from this area, okay? Let me go to the radiology presentation. So Dr. Vyad, it was an excellent presentation. Let me ask you a question from the group. Fat stranding, how early could be that finding? What would be the median onset of detecting the diagnosis early on, number one? And number two, should every patient have CT and MRI? When should I reserve the MRI? Please go ahead.
Yeah, as far as the first question goes, There is no time period mentioned in the literature, and that's probably because it's a variable factor. It's when the patient is presenting with the symptoms to the clinician and when the patient is being sent for the imaging. So we really can't tabulate a time frame when you will see fat stranding. I would think it would be somewhere in the range of a week or so, because we can extrapolate acute rhinosinusitis, non-fungal, getting complicated in that much time. So, but there is nothing in literature that says what is the earliest time that you could, in days, that you could see fat stranding. As regards the second question, as I mentioned in my talk, CT should always be the first imaging modality, I feel, before you jump into an MRI. When we find that the CT is normal and we are not really seeing anything disproportionate kind of clinical presentation as regards the imaging findings, that is for sure an indication that this patient needs to be bumped up to an MRI, because very early soft tissue inflammatory edema is better seen, optic nerve involvement is better seen on MRI than on CT.
Should we skip CT and go on to MRI directly?
No, I don't think so. Now, for sure, if it's coming from a specialist, like if it's coming from a neurologist who has very specific queries that I need to know if this structure is involved, if the optic nerve is involved, I need to know if the cavernous. So yes, in those situations, obviously we are going to go straight for an MRI. I'm talking about now, you see, everybody has jumped onto the bandwagon of sending for imaging. I'm getting referrals even from GPs, even from Ayurveda specialists, from homeopathic specialists also. So everybody sends for imaging. Now we can't have everybody coming in for MRI. MRI is specifically to answer very specific clinical queries, especially from specialists. Yes, we will definitely go for MRI with contrast first.
Good point. Thank you. Let me go to Dr. Pujari. A bunch of questions. I'm an ID doc as well. There are questions about role of hyperbaric oxygen, number one. Number two, if we suspect somebody with mucor and diagnosis is not forthcoming right away, should I start empiric therapy? And is there a role for prophylaxis? Those are three areas. Let's begin with. Dr. Pujari.
Yeah, so I'll start with the last question first. I have already mentioned in my slide about the role for prophylaxis is specifically indicated in two groups, neutropenic as well as GVHD. So it's not in the context we are seeing in COVID-19, predominantly diabetics with the steroid use. So at present, I don't think that we should be jumping into this bandwagon for prophylaxing. Otherwise, you will have a huge population which is eligible for that. And that would be really dangerous for the compound. The second question about hyperbaric oxygen, it has been tried out, especially in mucor associated with diabetes, predominantly the rhino-orbital variety. There is some encouraging results about that, but currently it is not really routinely recommended as an adjunct to the management of mucor. And what was the third question?
Prophylaxis, empiric therapy.
Oh, empiric therapy is something which is difficult to answer really. As far as possible, an attempt is made to get a diagnosis, and it is quite easy. It's quite easy to actually see, see the organism in either staining or histopathology. So you should make an attempt. In the meantime, if there is a delay, if there is a right clinical suspicion, and if the patient is also, pre-test probability is high that the patient is on steroids, there is hyperglycemia, ketoacidosis with the right clinical presentation, and if you are going to get a little delay, you may initiate until you get a diagnosis, empirical treatment. You should not perhaps wait for the diagnosis.
Yeah, I think that is important. By the time we get the imaging done and the surgery done, it may go through a few days. And studies have shown early treatment impacts on the ultimate outcome. So in this pandemic setting with a high index of suspicion, empiric therapy may be justified. I had read somewhere in the presentation today echinocandins can be useful. I just want to point out, echinocandins like caspofungin have no activity against mucor. So please do not use echinocandin either within the CNS or outside of the CNS, as the organism has no the drug has no activity. So essentially the drugs that you're left with are polyenes like amphotericin B and azoles. There are only two, isavuconazole and posaconazole. Voriconazole has no activity against mucor. And there are a bunch of questions in the chat. Please understand that Vori is active against aspergillus, but not against mucor. So I think we have a few minutes left. I'm going to go around, ask each speaker to make some final thoughts. Let's begin with Dr. Kulkarni.
So as we can see that the number of cases are increasing everywhere. I hope that everyone remains on toes for early diagnosis, early treatment of this disease. Now probably with increased awareness about the disease, the things may be a little better in near future, but we need larger data, maybe registries, some questions, some answers from the basic science, as well as some case control studies. And of course, we need some data on prevention of this disease. So there are a large number of unanswered questions. And I hope that webinars like this and further activity may help us to answer these questions.
Dr. Sanjay Vaid.
Can you hear me?
Dr. Vaid, yes, we can.
Yeah, I'm sorry, my video is off. Yeah, I'd just like to say that there is a bit of anxiety and panic situation also happening, because people are talking about fungal infection and mucor even in newspapers. So, I would really like to stress that referring for examinations like say CT and MR, which are costly, expensive examinations taking time, need to be channeled properly through a proper specialist, the ENT surgeon, the neurologist, so that we can address specific, and triage patients properly, rather than even doing some patients where imaging is not indicated. Thank you.
Absolutely. Yes, thank you. The third speaker, Dr. Pujari.
Yeah, my message really is prevention is better than cure. Steroids, use it in the right patient, in the right dose, at the right time, for the right duration. Monitor and treat hyperglycemia. These are the major risk factors. I request all physicians to really be serious about this. This is a very, very important issue. As far as mucor is concerned, unfortunately, if patients do develop it, early diagnosis, early treatment, aggressive surgical debridement, and controlling underlying disease, and rational use of drugs. It's very important, because we saw a large amount of irrational use of drugs like remdesivir, etc., happening in the context of acute COVID. So I fear that you may start seeing irrational use of azoles, particularly in this context. So please avoid this. These are very, very useful drugs in the long term for us.
Absolutely. I echo these statements as well. I was talking to the chief of ID at Christian Medical College, Vellore, a couple of days ago, and his observation is polypharmacy is a huge problem among internal medicine, family practice doctors. Multiple drugs are being thrown at these people, at patients who are infected with COVID, and there is enormous amount of drug interaction and drug toxicities on our patients. So please be mindful of what drugs we are using on these patients, and please use only those that are evidence-based. The last comment is from the surgeon, Dr. Gadre.
Yeah, it's a multidisciplinary approach. We are in this together, and we have to come out of this together. Prevention is the best choice. Early detection and eradication of disease is what is required.
Great. Thank you so much, everyone. Now I'm going to hand over to Dr. Meshram. Dr. Meshram, thank you.
Yeah, thank you. Dr. Steve Lewis, any comments? Steve?
Yes, thank you so much. First of all, this was an absolutely incredible webinar. I knew very, very little about this epidemic within the pandemic until today, frankly. And I want to thank you, Dr. Meshram, thank Dr. Chandrasekar, all the speakers, all the course directors for letting so many people know about this. Both, I think there were about 450 people online, and many more to come on video, I'm sure. I think this was really a life-saving event, and we learned a lot about prevention, early diagnosis, and I think you're all to be commended for bringing this up so quickly and putting together such an incredible webinar. So thank you so much.
Thank you.
May I say something, Dr. Meshram?
Yeah.
Yesterday, we had the Infectious Disease Society of America, a special meeting, just convened about the situation of COVID in India in general, not just about Mucor. There is a lot of concern among various American medical societies, and they are wanting to help. They just don't know how. How can they intervene? How can they interact with the various medical societies of India? They are very willing to help. They just don't know exactly how they can provide the help. So I would urge you through the Indian Academy of Neurology and other societies to interact. And if it is anything to do with infectious disease, I will be happy to step in and be the intermediary. Or through Dr. Rajamani, you can communicate with the American Society. And certainly with hands together, we can conquer this problem.
Thank you, Dr. Chandrasekar. Thank you very much for offering this support.
Professor Visold, Secretary General of World Federation has just left, so we cannot have comment on this. Over to Dr. Meenakshi Sundaram. Dr. Nirmal, you want to make some comments?
Thank you, sir. I think it has been a wonderful webinar. To put up such a webinar at such a short notice isn't that easy. And to have 450 plus almost 500 people attending shows the interest in the topic amongst all the practicing physicians, surgeons, everyone. It's a topic. I think the number one point we'll all probably take home is to handle steroids responsibly. I think that's the most important point, if any. And I think as a physician, we all know that steroid is a double-edged weapon, and we need to handle it pretty carefully. Thank you very much. I think I would, first of all, thank Dr. Rahul Kulkarni, who was instrumental in initiating the discussion and has been working on it pretty diligently. And thank you, Rahul. Thank you, Dr. Sanjay Vaid, for those very interesting notes on the imaging aspects, about how the CT can be better than the MRI and many other aspects too. Dr. Sanjay Pujari, thank you very much. Those were very, very good guidelines on how to handle the antifungals. And we still have to use at sometimes the amphotericin deoxycholate, but it happens because of economic reasons. As someone has pointed out in the chat, the rates of amphotericin, liposomal amphotericin have gone up. And so some people can't afford it. So it's important. And I think we will have to do something about it, maybe write to the government. We will probably discuss and take it forward. And Dr. Pushkar Kadre for that extensive talk on the surgical aspects of management of mucormycosis. Dr. Vikram Oak for his expert comments. And of course, Dr. Chandrasekar for so expertly coordinating all that. I really like the way you handle the question and answer session when there were 80 questions or something, and how you put them all together and pointed it out to each one of those faculties. Nice learning. It was very, very nice, very expertly handled. That shows your experience in handling this. As most of us have been doing this on Zoom many times. Thank you so much, sir. It is real pleasure looking at you. By the way, Wayne State is pretty close. Dr. Ramesh Madhavan is a very close friend. He used to be
I
there.
see. Yes.
He's been there. So
Right.
thank you all. I have to thank Dr. Nirmal Surya for leading the way, as always, and Dr. Chandrasekar Meshram, who has been instrumental, who has been the convener of all our CME programs, and is always energetic and is always fresh, whatever time we see him. Thank you very much, sir. Thank you for doing the work.
Thank you, Professor Steve, for being with us.
Yeah, thank you, Professor Steve, for being with us.
I just wanted to
Thank you.
Just wanted to let people know that we have already written to the government about the mucormycosis, and Dr. Chandrasekar will come back to you because we don't know how COVID is affecting the immune system, and it would be really wonderful to learn and know if there is a data which suggests that COVID itself is affecting the immune system, and those who have associated diabetes would work out. So we will look into this. Of course, tropical neurology subsection is working. We'll come out with a couple of more guidelines, programs for the people, our community, not only our community, but for the physicians, lay public, so that there is no fear come into the people. We know this is a disease which has got terrible prognosis, but we would certainly want people to know exactly. My two thoughts was, would it be helpful when people are doing the CT chest for the diagnosis of COVID? Could a couple of 2 sections for the PNS could help you in picking up an early infection, and in those patients, you can prevent the mortality. Just a thought, because now the CT has become a standard in India for the chest, for the COVID. People don't do the RT-PCR, but they do that. Second, my just thought is, would an antifungal spray in early diagnosis, particularly in people with a steroid or something, would help you, or there is something, nasal spray or nasal wash. At Baba Ramdev used to do a nasal cleaning, would have water with some antifungal or some permanganate solution just to clean the nose and let the things come out would be helpful. Some simple method, but we will really need to look into all these techniques, and maybe some cheaper thing we have to come out with our own local thing. Thank you very much, and I say good night to everybody. Meshram, your last comment.
Thank you. Thank you all.
Thank you. Thank you all. Thank you. It was a wonderful session. Thank you very much. Thank you, Mansi.
Yes, so thank you, sir. Actually, Bhavesh sir was the one managing the session today.
Okay, but you forgot to project. Then I realized that.
No, actually, sir, I got disconnected from the meeting.
Okay.
That is why Bhavesh sir had to share the slide.
No, I have shared the slides.
Okay. I'm sorry. I thought he shared the slide.
No, I shared the slides.
Okay.
Okay.
Yes, sir. Okay.